Picture this. You've just had a massive, heavy, fatty meal. Then, suddenly, a sharp stab of pain right under the right ribs. And then, a clinical sign that literally stops your patient's breath mid-inhale. If you're a nursing student, you need to recognize this presentation immediately.
Welcome to The Explainer. Today, we're tackling the exact pathophysiology and nursing management of cholecystitis that you need to know to absolutely crush the next-gen NCLEX. We're going to build this visually, step by step, so these facts stick in your brain for good. Let's get into it.
Okay, here's our game plan for today. We'll hit the pathophysiology, the signs and symptoms, diagnostics and priority interventions, patient teaching, and finally, a quick NCLEX test yourself section to lock it all in.
Starting off with Section 1, Pathophysiology, the blocked duct. Let's trace the cascade here. Step 1, a gallstone physically lodges in and completely obstructs the cystic duct. It's kind of like a cork jammed in a bottle. Step 2, because that duct is blocked, the bile has absolutely nowhere to go. So we get bile stasis. The bile gets trapped inside, distending the gallbladder like a water balloon. Step 3, this backup causes the walls to get inflamed, swollen, and hey, bacteria might even crash the party and start infecting it. And finally, Step 4, the pain trigger. When your patient eats a fatty meal, their body says, hey, release bile, which stimulates that inflamed gallbladder to contract directly against the blockage. That squeeze, that is exactly what causes that agonizing right upper quadrant pain.
So who's actually most at risk for these gallstones? I want you to burn this memory trick into your brain right now. The 4 F's: female, 40, fat, and fertile. You are going to see this classic patient profile in your test questions over and over again. But keep an eye out for other key risk factors hiding in the background of a question too. Things like a recent history of rapid weight loss, a high-fat diet, or the use of oral contraceptives.
Moving on to Section 2, Signs and Symptoms, the classic presentation.
All right, so here is exactly what you'll see on the floor. The absolute hallmark sign is that right upper quadrant, or RUQ pain. But listen to me, here is the most tested detail. That pain radiates straight to the right shoulder or scapula, specifically after they eat those fatty meals. You'll also see typical inflammation signs, nausea, vomiting, fever, and an elevated white blood cell count. Oh, and note this carefully. If that stone happens to travel and blocks the common bile duct, that's exactly when you're going to see jaundice appear.
Now, pay close attention because this right here is a massive NCLEX trap, Murphy's sign. The textbook definition is inspiratory arrest with right upper quadrant palpation. But what does that actually mean in real life? Well, it means when you, the nurse, press down on the right upper quadrant under the ribs, that angry, inflamed gallbladder hits your fingers. The pain is so sharp that the patient abruptly stops breathing in. If they gasp and stop inhaling, bingo, that is a positive Murphy sign. And it is a massive flashing red light for cholecystitis.
But things can escalate, and you need to recognize danger immediately. Enter Charcot's triad. If your patient suddenly develops a high fever, combined with jaundice and worsening RUQ pain, this is a medical emergency. It means the infection has spread to the bile ducts, causing cholangitis. An unrelieved obstruction like this can lead to ischemia, gangrene, perforation, and even sepsis. Bottom line, if you see Charcot's triad, you must act fast.
Section 3, Diagnostics and Priority Interventions. So first up, how do we actually diagnose it? Do not let the exam trick you here. An ultrasound is always your first-line test for cholecystitis. It's fast, it's non-invasive, and it immediately shows stones, wall thickening, and fluid. Now a HITA scan, that checks the patency of the cystic duct. Basically, if the gallbladder doesn't fill up with the radioactive tracer, you've got an obstruction. And finally, a CT scan is primarily used if we suspect severe complications like an abscess or perforation. But remember, always pick ultrasound first.
So, the crucial point here is knowing your priority nursing actions ranked in exact order. Number 1, pain control and making the patient NPO while starting IV fluids. Why? Because being NPO rests the GI tract. If there's no food, the gallbladder isn't stimulated to contract, and that gives it a break and relieves the acute attack. Number 2, administer antibiotics if there's an infection to prevent sepsis. And number 3, prepare the patient for a cholecystectomy, which is the definitive treatment to remove the diseased gallbladder entirely, usually done laparoscopically.
Let's look at Section 4, Patient Teaching and Recovery.
When you're teaching your patient post-op, the single most important dietary rule is this: a low-fat diet. Tell them they absolutely must avoid fatty and fried foods initially. This reduces biliary stimulation. Then, they can start to reintroduce fats gradually over time. Also, here is a huge post-op tip.
If they had laparoscopic surgery, warn them about referred right shoulder pain. It's actually caused by the CO2 gas they use to inflate their abdomen during the procedure. Getting them up and walking, early ambulation, helps absorb that gas. Finally, for open procedures, make sure to teach proper T-tube care and closely monitor for any dangerous bioleaks.
All right, Section 5, NCLEX, test yourself. Let's see what you've got.
Question 1. During assessment of a client with suspected cholecystitis, the nurse presses on the right upper quadrant and the client abruptly stops inhaling due to pain. This is A. Cullen sign, B. McBurney's point tenderness, C. a positive Murphy sign, or D. Robsing sign. Drop your answers below right now. 3, 2, 1.
And the correct answer is C, a positive Murphy sign. Remember that inspiratory arrest with right upper quadrant palpation is the absolute hallmark physical exam finding for a highly inflamed gallbladder and cholecystitis. Awesome job if you got that one right.
Let's keep this momentum going. Question 2. After recovering from cholecystitis, the client should be taught to follow which diet? A. Low-fat diet. B. High-fat, high-protein. C. High-fiber, high-fat. Or D. Unrestricted diet immediately. Lock it in. 3, 2, 1.
The answer is A, a low-fat diet. Dietary fat stimulates the gallbladder to contract. So by keeping the diet low in fat, especially right after an attack or a surgery, we drastically reduce that stimulation and prevent that agonizing pain from coming right back.
You absolutely nailed it today. If you take away just one thing from this explainer, remember this memory hook. Fatty food leads to right upper quadrant pain, which radiates directly to the right shoulder. But I want you to think about this. If that gallstone travels even farther down and actually blocks the pancreas, what life-threatening complication are you dealing with next? Let me know your thoughts in the comments. And hey, if this explainer made cholecystitis finally click for you, hit that subscribe button. We are breaking down one killer med-search topic every single day until you pass the NCLEX. Keep studying hard, and I'll see you in the next one.